Welcome to our section on pediatric cardiology, where any discussion starts with congenital lesions, as they are highly tested topics on step 2. Congenital lesions are largely divided into two groups, cyanotic and acyanotic lesions, those that make the baby blue and those that don't. We're going to focus on cyanotic lesions here right now. These are the 5 cyanotic congenital heart problems we're going to discuss. The primary goal as a step 2 test taker in going through this section is what stands out to differentiate each illness from the other. That is, if I only told you that a child had a cyanotic heart lesion, what information will most efficiently let you rule certain diseases out and others in? To start off, you've got to know that tetralogy flow is the most common cyanotic heart defect in children. Emphasis on cyanotic. And this is to clue you in that you're more likely to hear about this defect than the others just due to its commonness alone. You probably recall from step 1 the 4 components of tetralogy of flow. They are pulmonary stenosis, a ventricular septal defect, VSD, an overriding aorta, and a right ventricular hypertrophy. So now we're going to review how these 4 components come together to affect the flow of blood in the heart and the whole body oxygenation. These congenital heart defects can be tricky to distinguish from one another clinically. They're not going to give you a diagram spelling out the diagnosis like we're going to go over here. The underlying physiology is directly related to the symptoms, diagnostic maneuvers, and any treatments you might give. So we're going to go through a diagram of each of these heart defects, and hopefully by understanding the physiology, you'll be able to understand the clinical presentation and get these questions correct on step 2. Starting with this diagram of tetralogy of flow. Note the 4 components. There's a pulmonary stenosis, which here is labeled as right ventricular outflow obstruction. There's an overriding aorta, a VSD connecting the right ventricle and the left ventricle, and there's right ventricular hypertrophy / dilation. Note that see that the right ventricle is bigger than the left ventricle. Even though the wall isn't necessarily thicker, this is to imply that RVH, right ventricular hypertrophy, doesn't always look in a diagram like thicker muscle. It's often just a bigger ventricle. So starting with blood in the right atrium, which is deoxygenated, it moves into the right ventricle as normal, and it can go one of 2 places. It can go through the stenotic valve and go onto the lungs, returning to the left atrium as oxygenated blood as normal, or deoxygenated blood can move from the right ventricle directly into the left ventricle. Here, it combines with the oxygenated blood from the left atrium to make a sort of pseudo-oxygenated blood, shown here as a purple dot. Now this blood will continue through the aorta and into the systemic circulation, eventually returning to the right atrium as deoxygenated blood. The question is, what promotes blood flow either through the stenotic pulmonary valve, which is what we want because we want deoxygenated blood to go to the lungs, or what promotes it to go through the VSD? And the answer is pressure. Systemic pressure and pulmonary pressures matter a great deal here. The right outflow obstruction already makes it difficult for blood to flow through the valve and to the lungs. So when the child does anything that lowers the systemic resistance, that lowers pressure in the systemic vasculature, that will make it easier for blood to flow from the right ventricle and into the left ventricle, and that promotes cyanosis and makes the kid turn blue. So go over that diagram again until this all makes sense to you, and you can predict the flow of blood in the different scenarios, changes in pulmonary and or systemic pressure. And I hope now it's clear why this is called a cyanotic defect. Now speaking of cyanosis, the cyanosis that occurs in TOF as well as the other cyanotic heart disease tends to be more subtle. It's usually involving the lips and the extremities. It's not that their torso turns blue or their whole leg turns blue. It's in the small capillary beds of their lips and their fingers. Now, often you might see in a vignette that, child's running around, becomes short of breath, and then starts to squat and feels better. These can be termed TET spells, and the reason children with TOF squat is because it increases There's systemic pressure. It increases the pressure in the systemic area, which gets transferred back to the aorta into the left side of the heart. This allows blood to be shunted away from the left ventricle and back into the right ventricle, and is diverting blood appropriately from the right ventricle into the pulmonary vasculature, so it can be oxygenated the way that it's supposed to, and come back to the left side of the heart via the normal system. Now, the VSD that these kids have causes a holosystolic murmur. The murmur will be louder when the VSD is smaller. The murmur will be quieter when the VSD is bigger. So it's just something to keep in mind. If you hear a very, very loud holosystolic murmur and you know the person has a VSD, it means it's probably a smaller VSD. And then a tip to know here, specifically thinking of holosystolic murmurs, is that there are only 3 holosystolic murmurs. They are mitral regurgitation, which is the most common, tricuspid regurgitation, and VSD. So here's a chest film of a child with tetralogy of flow, and the term used to describe this chest film is a boot-shaped heart for obvious reasons. Or maybe not so obvious, maybe it doesn't look like a boot to you. But regardless, you can see that the right heart border is bowing way out, secondary to right ventricular hypertrophy, one of the 4 features of tetralogy of flow. There's also decreased vascular markings. Decreased vascular markings because there is less blood flowing through the pulmonary vasculature than there should be, because it's flowing through the VSD into the left ventricle. This is all I really want to mention about tetralogy of flow. If there's one heart defect to know, it's this one. There's a great deal of variation in what they can ask you on the test about this one disease. For example, they might spell out the diagnosis, making TOF seem obvious, only to give you a recording of a heart murmur and ask you, what type of murmur is this? So it comes down to you knowing less about TOF and either remembering a VSD as a holosystolic murmur or knowing what it sounds like. But take my word for it, those heart sounds are not easy to hear on the test, and they're not necessarily helpful. So knowing the clinical presentation is better than being able to hear and recognize a holosystolic murmur. The treatment for this is going to be surgical correction, and they patch the VSD that was there. So that's, all the congenital heart defects are usually surgically corrected. So surgery is not usually going to be a question as far as management that you're going to see on the test. The next defect we're going to discuss is transposition of the great vessels. And this is exactly what it sounds like. The aorta is where the pulmonary artery is supposed to be, and the pulmonary artery is where the aorta is supposed to be. This, in effect, creates 2 separate circulations. You have the right side of the heart, which is devoted now to just systemic circulation. Blood in the right atrium goes to the right ventricle, and then out in aorta to the whole body, only to come back to the right atrium. Not good. Then there's the left side of the heart. Left atrium, left ventricle to the lungs, only to come back to the left atrium again. And the big catchphrase for this type of heart defect is that it's defect dependent, that you have to have a way for the left and the right circulations to communicate, or it's not consistent with life. That means there has to be a patent ductus arteriosus, a PDA, a ventricular septal defect, a VSD, or an atrial septal defect, ASD. If none of these exist, then this child's not going to live without surgery in utero or beforehand, and that's not good. So if the child's born and turned blue, that means in breathing and living, then that means one of these defects is there. It's just a matter of figuring out which one. A tip is that this is the most common cyanotic lesion in neonates, where TOF was the most common cyanotic lesion diagnosed in children. This is the most common one in neonates, those under the age of 28 days. Here's a diagram of how transposition of the great vessels plays out. So we start with deoxygenated blood in the right atrium. Like normal, it goes to the right ventricle, and then it inappropriately goes through an aorta and into the systemic circulation, not giving any oxygen to any organs that need it, only to arrive back in the right atrium still deoxygenated. The same thing happens on the other side. Oxygenated blood in the left atrium goes to the left ventricle as normal, but then goes through a pulmonary artery into the lungs where it, gets more oxygenated, only to arrive back in the left atrium, not having visited any organs that need its oxygen. So the kicker is there has to be some defect for this person to survive. And that's either in the form of a connection between the aorta and the pulmonary artery, called a PDA, an atrial septal defect, or a ventricular septal defect. That will allow oxygenated blood in the left atrium to go through the pulmonary vasculature that's attached to the left ventricle, but it sneaks through the PDA, and then it gets to the systemic circulation. Or it can jump over to the right atrium through an ASD, and then it goes through the right ventricle and the aorta to the systemic circulation. Or it goes through a VSD from the left ventricle to the right ventricle, and that takes it through the aorta and into the systemic circulation. All this seems very backwards, so go through this a couple times if that will help it make more sense to you. But the bottom line is that one of these three defects, or maybe more than one of them, have to exist for this congenital heart disease to be consistent with life. So the question remains, what are we going to do about this? Obviously, there's going to need to be surgery because you need to put the aorta where it's supposed to be and the pulmonary artery where it's supposed to be. But we also need to do something for these children because they're defect dependent that bridges them to surgery. So we give them prostaglandin E. Now, because this is a defect dependent disease, you give prostaglandin E to keep PDAs open. You want to keep the patent ductus arteriosus. You want to keep the ductus arteriosus patent. So you give prostaglandin E that keeps the PDA from closing as it naturally does right after birth or within hours and days after birth. And you, at all costs, do not give NSAIDs. NSAIDs are avoided because things like indomethacin cause the PDA to close. So give prostaglandin E, don't give NSAIDs, and then eventually this kid's going to need surgery. And unfortunately, surgery has a very high mortality. So the next syndrome we're going to talk about is hypoplastic left heart syndrome. And there are three major components to this that we're going to make very clear with a diagram on the next slide. But those three major components are absent pulses, there's a lack of a properly sized and pumping left ventricle. So pulses, which are normally formed by the force of the left ventricle, thrusting blood into the aorta and into your systemic circulation, there's no left ventricle in these kids, so they don't have pulses. They have a right ventricular heave, which is really just a manifestation of right ventricular hypertrophy. So without a left ventricle, you can imagine that their right ventricle is doing twice the work, and so it's gonna get big, it's gonna get strong, and it's gonna create a heave when you do a physical exam in these kids. And then last is cyanosis. All the defects we're discussing in this lecture are cyanotic heart diseases. So these kids tend to be like grayish, or they can develop the peripheral cyanosis in the lips and the extremities, as we discussed. So here's our diagram of hypoplastic left heart syndrome. And at first, everything appears normal, or at least starts that way. Deoxygenated blood in the right atrium moves to the right ventricle. It goes through the pulmonary artery and through the pulmonary vasculature and arrives in the left atrium oxygenated as it's supposed to. But it's at this point that our flow encounters a problem. There can be mitral valve atresia, meaning no mitral valve. There can be left ventricular hypoplasia, an underdeveloped left ventricle, or there can be a distorted, messed up aortic root. All of it making it difficult for blood to flow through the left ventricle and into the systemic vasculature as we want it to. So what happens is our blood in the left atrium is often forced through either an atrial septal defect or what is just physiologically a patent foramen ovale, a PFO. This blood mixes with pulmonary venous return, creates a sort of mixed oxygenated, deoxygenated blood, which is better than nothing, goes to the right ventricle, and then makes its way through a PDA connecting the pulmonary artery and the aorta so that it can send this partially oxygenated blood to the systemic vasculature and giving oxygen to organs that vitally need it. Two important points to make here. First is the dependency on a patent ductus arteriosus, just like we saw in transposition in the great vessels, which means how is this kid going to be managed right as they're born? Prostaglandin E1 and no indomethacin. Even if there's an ASD and there might be another way that the bloods are mixing, you want to keep the PDA open because it's likely helping this child. The second is that this compensation of this PDA with this PDA and the ASD is only half good, because half of the shunted blood, see, it's partially deoxygenated, ends up going back to the pulmonary vasculature so that it can get oxygenated and go back to the left atrium. So the systemic demand for oxygenation is actually revved up, and this puts an increased strain on the heart, which causes it to pump faster and harder. But the only ventricle that's doing any work is the right ventricle. So this leads to right ventricular strain, right ventricular hypertrophy, and eventually dilation. So you not only have an underdeveloped or non-existent left ventricle, but you end up having a wrecked right ventricle too. Now on to truncus arteriosus. Truncus arteriosus is when there is one great vessel overriding a VSD. Recall that in tetralogy flow, we had an aorta that overrode a VSD. But in here, it's just one big vessel that overrides a VSD, and the pulmonary vasculature kind of comes off this big vessel. We'll make this clear in the diagram on the next slide. That's different from tetralogy of flow, where in TOF, we had a pulmonary artery, it was just very stenotic. Now, truncus arteriosus is very rare compared to the other defects. It's only 2% of all defects. So we're going to focus on how this plays out physiologically and what's the primary management of that. This is also not dependent on a PDA. So you do not, these kids with truncus arteriosus do not require prostaglandin E1 to live. They just ultimately are going to require surgery. And the cyanosis in truncus arteriosus is actually mild. Because they have a mixed pool of blood that's going to the whole system, they don't develop the cyanosis as prominently as you see in things like transposition in the great vessels or even in TOF. The big problem in truncus arteriosus is pulmonary hypertension. Think about it this way. You no longer have proper divisions between the right side and the left side of the heart. Normally, the left side of the heart generates much higher pressures to push blood through the systemic vasculature. The right side of the heart doesn't have to generate as high a pressure to put blood through the pulmonary vasculature. But if you put those pieces together and they have to share basically one big ventricle to go through one common artery, then the same pressures that are going to be applied to push blood through the whole body are now being applied to push blood through the pulmonary vasculature. This creates incredible pulmonary hypertension and can lead to irreversible pulmonary vascular damage. And that's why you have to correct this with surgery. So here is a quick diagram of truncus arteriosus. We have blood, deoxygenated blood in the right atrium, oxygenated blood in the left atrium. They meet in the middle because there's a giant VSD, and they form a pseudo mixed oxygenated blood, which goes through a common truncus and can go through the part that really becomes the aorta and into the systemic vasculature, or the mixed blood can go through an offshoot of the main great artery and to the pulmonary vasculature where it becomes oxygenated. All the blood returns to the heart as normal as either deoxygenated blood in the right atrium or oxygenated blood in the left atrium. Note that the ductus arteriosus is closed. There is no PDA and it's not contributing to any shunt. This is a right to left shunt causing cyanosis because the systemic venous return is getting sent back into circulation, and the more that happens, the more it contributes to a cyanosis. But in ways, this acts a lot like a left to right shunt, which we'll talk about in another lecture, but it puts an incredible load on the right side of the heart and causes pulmonary hypertension, which we see a lot in left to right shunts. The last defect we're going to discuss is total anomalous pulmonary venous return. I think this is the defect that is least likely to show up on your test, so we're just going to go over it quickly, and we're not going to have a fancy diagram with it. So in this defect, you basically have, exactly as it sounds, you have pulmonary blood returning from the lungs and going to the wrong place. Instead of going to the left atrium as it's supposed to, it shows up in the right atrium. This is bad because you need oxygenated blood going to the left atrium so it can send it to the left ventricle into the systemic circulation. If it shows up in the right atrium, well then you need to somehow get that now pseudo-oxygenated blood to the left side of the heart to pump it to the rest of the body. So often they are dependent on a patent foramen ovale. Not necessarily an ASD, but a PFO is enough to keep these children alive, because that blood has to get from the right side to the left side. So this leads to right heart overload. If the systemic venous return is coming to the right side of the heart and the pulmonary venous return is coming to the right side of the heart, you got an increased load to the right side of the heart, and it leads to a strain like we see in the other 4 cyanotic heart defects. You get right ventricular hypertrophy, a right ventricular heave, and eventually right ventricular dilation. That's all bad. And then last thing you need to know is there are 2 types of total anomalous pulmonary return, and there's those with obstruction and there's those without obstruction. And that's basically labeling whether there's obstruction or not of the pulmonary vessels as they enter the right atrium. This table is intended to outline the simple differences between those with and without obstruction and total anomalous pulmonary venous return. Those with obstruction are going to have it worse off. They're going to present very early in life with severe respiratory distress and severe cyanosis, because not only do they have the problem with their oxygenated blood showing on the right side of the heart, but they actually have an obstruction to that blood even getting to the right side of the heart. The best test is going to be a chest x-ray, which shows a pulmonary edema. That's going to be your first test, because if somebody shows up in respiratory distress, a chest x-ray is a common thing. But the best test to order is going to be an echo. An echo is going to show a very clear, circulation of the heart in children this small. And then treatment's going to be surgery. That's obvious. You got to put the pulmonary veins back where they're supposed to in the left atrium. Now, those without obstruction aren't clinically as worse off, so they can age a little bit before they actually present, and they'll show up with basically heart failure. And it's predominantly right-sided heart failure because of that overload and the strain from the pulmonary and the systemic venous return showing up on the right side. The right ventricle basically craps out. The test in both situations is an echo. You'll still get a chest x-ray. You might hear the term snowman sign, but I really don't think the chest x-ray is going to be of highest yield for you on this test. On your step 2. You need to know that echo is how you're going to diagnose total anomalous pulmonary venous return. And then treatment is the same for both. You got to correct it. You got to put the pulmonary veins where they're supposed to, and that can only be done with surgery. To end the lecture, I like to quickly bring a few of the concepts together that link all the cyanotic heart defects, the 5 that we've discussed in this lecture. And let's put them all on one page, and so you can compare and contrast them, so that when a young child or even an infant presents that's blue, and the assumption is that it's a cyanotic heart disease, what facets of the vignette are going to help you best rule some things out and rule other things in. And then you'll know what things need to be done for the different diseases. And so they're all right to left shunts. But only 2 of them are PDA dependent. Can you remember? It's the middle 2. It's transposition of the great vessels and hypoplastic left heart syndrome. Think of those 2 as PDA dependent. And then which 2 have VSDs? And if they have VSDs, remember VSD is only one of the 3 possible causes of a holosystolic murmur. Tetralogy of Fallot and truncus arteriosus. Remember, they both had an overriding artery, aorta, hanging out over a VSD. They both have to have a VSD to be the congenital disease that they are. And then the treatment for all of them is ultimately surgery. But remember, the ones who are PDA dependent must get prostaglandin E1 and must not get indomethacin or NSAIDs.